Our last point here brings us to rapid squatting. A couple of things that you want to keep in mind with rapid squatting. Well, is there a maneuver that you as a clinician are performing or asking the patient to do to figure out as to what kind of murmur your patient might be suffering from? Or a maneuver that a child would be conducting to relieve a particular symptom that the patient might be feeling. So what are we getting at here? So with rapid squatting, or squatting in general, what you want to do is you want to be able to delineate the two conditions in which squatting becomes beneficial. For a clinician, in which you want to see as to whether or not the intensity of the murmur is going to increase or decrease, and you ask the patient to conduct rapid squatting, then blood will be returned to the heart in an increased fashion. Is that clear? Now, what about this patient? Ready? You have a child. They love to play. They ask, Mommy, I want to go play hide and seek. And, well, at some point, when the child is seeking that hiding place, the child gets tired, and the child squats, but not to increase venous return. The child is instinctively squatting because the child feels tired. The child has hypoxemia. The child is experiencing cyanosis. The child might have pulmonic stenosis, right ventricular hypertrophy, ventricular septal defect. Those three will give you the clinical picture of your patient. And what's that picture that I'm referring to? And why those three? Pulmonic stenosis always begin there. Right ventricular hypertrophy and ventricular septal defect result in what kind of shunt in that case, please? It's one of the most common congenital cyanotic heart disease, and it's called tetralogy Fallot. But Dr. Raj, you only gave me 3. I thought tetra means 4. Why being so foolish, Dr. Raj? Because I'm giving you the 3 in which it gives you the clinical picture. What were those again? Number 1, pulmonic stenosis. Number 2, right ventricular hypertrophy. Number 3 was ventricular septal defect resulting in a right-to-left shunt. Interesting. A VSD, in that case, would be a right-to-left because of the other predisposing issues. And the 4th and final, tetra, would be the overriding aorta. Now, why am I bringing this up? Because that squatting maneuver that the child was performing instinctively was then causing increase in TPR. Our discussion earlier with TPR was what? When you increase your TPR, what does it do to your afterload? Good. It increases afterload. If you increase that afterload, then what are you doing with the left ventricle? You're increasing the resistance that the left ventricle is facing. So now at this point, with that child feeling cyanotic with the squatting maneuver, is then going to reverse that right-to-left shunt to a left-to-right shunt. And by doing so, relieve some of that cyanosis. Is that clear? So we have squatting in 2 different conditions. What we have here is the fact that it increases venous return upon rapid squatting. So that would be to the right side of the heart through your veins. And then that child with tetralogy Fallot, that squatting would be conducted or performed to relieve the symptoms of your patient.